in the classroom. It's kind of new for us and for you guys on webinar land. Usually we have a speaker in the front of the class, but Dr. Antevy is remotely on webinar land with us from Houston. Is that correct, Dr. Antevy?
Yeah, yes, today I'm in Houston.
Yeah, he's in Houston today. So it's kind of crazy technology. It's awesome and amazing. So you guys get to watch the screen with us and hear him talk. For those that's in the classroom, just any paperwork or if you're getting any snacks, any kind of noises you make will come across the recording. So if you can tear out papers now or get crunchy stuff out of the way now, that'd be great. And for those of you in webinar land, before we get started, if you guys can just take a look, there's a raise hand function on your screen. If you can do the raise hand function now, just so we know you guys can all hear. I see everybody putting up their hands. Perfect. And so I just ask, you guys can put your hands down. I just ask that if you guys have any questions, you can kind of just type it in the chat box or the question box, and Dr. Antevy will get to it. I will answer them as we go along, but if it's a burning question, just go ahead and ask it, and then I will interject. I need to open up if you have the capability to have a mic, or I'll just ask the question for you. So if it's a question that you have for him, just write that you have a question for him, and we'll go ahead and at the next available opportunity open up for you to ask your question. So everybody in here, if you can just silence your cell phones, we'll be good to go. So I'm very excited to announce that we have Dr. Antevy. He has a laundry list of titles, so I don't think I'm going to do it justice. I'll spend here all night giving all his titles, so I'll have him introduce himself. Dr. Antevy, we're very excited to have you. Go ahead.
Okay, thank you very much for having me, Ms. Zelda. I appreciate it. I wish I could be there with you guys personally in Alaska today, but unfortunately I cannot. And thanks everyone for spending the next couple of hours with us. Hopefully it'll be entertaining, it'll be a little interesting, and please ask questions, the more the merrier, and we can get started. So as far as my background is concerned, I'm a pediatric emergency medicine physician. But 5 years ago, I became an EMS medical director. Don't ask how that happened. And that really changed my entire life. I basically spend about 60% of my time now with EMS. I work with over 2,000 paramedics, spans three different counties. I work with 2 different paramedic schools. We have over 1,000 students in those. And so EMS is really something that I probably should have gone in from the very beginning. I think that's what I was meant to do. And now I'm able to take my pediatric experience and now see exactly what's happening in EMS and really understand the real problems, because it turns out that all the people that taught you pediatrics and that gave you all these courses and told you what to do in pediatrics, none of them actually do what you do. None of them are in the field. They're in some ivory tower telling you what to do. And so I've come full circle in my career, and hopefully this talk will make you probably have a lot more questions than answers maybe. But a lot of what you're going to hear today is not what you've been taught, and maybe exactly the opposite. So it's meant to be a little stimulating, maybe a little irritating to you, and that type of thing. So hopefully you'll enjoy it. At the very end of the talk, we'll talk about some of the things that we've done as far as what we've created to help paramedics out there get the job done correctly. So I do want to start by saying that I do have a disclosure, and when I speak nationally, whether it be a webinar or live and in person, I usually never talk about the system that I created, just because I just don't feel that that it's really appropriate for the audience. But today I was specifically asked at the end to talk about the system because we are implementing already in some places in Alaska with Dr. Levy and so forth. So at the end you'll get a couple of slides and just a short, maybe 5 or 10 minutes at the very end. So I appreciate that as well. So I wanted to start off by talking about this road, which is somewhere in Middle America. And you can see that this road is very dark and it's curved. And it turns out that this road, every year, people would come to this curve and they would just speed around the edge. And it turns out that there were about 100 deaths in 1 year in this particular road. And I'm going to make you the city manager, the city mayor, the engineer. What would you do if you had 100 deaths in 1 year in this particular road? And I know that I can't hear your microphones and so forth, but most people say, oh, just put a couple of lights up there, right? And everything will get better. Well, it turns out that when they added lights to this road, what do you think happened to the death rate? The death rate went up. And so you're going to say to yourself, well, how could that be? Well, it turns out that when you're driving down this road at nighttime and it's dark, your brain says, you know what, we should slow down a little bit. When you're driving towards a curved road at night and it's very well lit, you end up speeding up and staying in a fast pace, and you end up having more deaths. And so the moral of the story is that when you encounter a problem, such as a dark road where people are dying, you have a few options. And people will start to have all their little, things, put some lights, put some guardrails, do this and that and the other thing. And sometimes the things that we do to fix things make things worse. And that's basically a summary of what's been happening in pediatrics over the last 30 years. And I'm hopefully I'll tell you that story in more detail. So I want you to remember this story, and then we'll get to it at the very end, and hopefully you'll kind of see what my point really is with pediatrics. I'm going to start with this curve, because this is the curve that keeps me up at nighttime. This is the curve that we are going to change before they put me 6 feet under the ground. This is us in EMS, okay? This is the out-of-hospital survival curve for cardiac arrest in pediatrics. So how could it be that since 1980, it's been 30 plus years, and the out-of-hospital survival from pediatric cardiac arrest hasn't changed one iota? In the hospital, the red curve, you can see we've done a lot better. So if I was sitting right in front of you, you would probably say things like, kids are different, it's more anxious, the parents are nervous, the doctor at the hospital told me to show up at the hospital as fast as I could, I don't see pediatrics that often, and on and on and on, and the excuses keep rolling. They keep rolling. And I actually bought into that for many years until I've been doing this now for 16 years, and I can tell you that the last eight of these years, I have a completely different concept of what's really going on, and this talk explains what really is going on right here, and hopefully that'll come through today. And so where do those statistics come from? They come right from this paragraph, this is 2015 Pediatric Advanced Life Support. You guys, I'm sure, have seen the document online. And you can see here that if you're a child under the age of 1, an infant, your chance of survival from out-of-hospital arrest is only 3%. And we know that because those are the kids who are what we call the SUIDS deaths, or as we once used to call SIDS deaths. Those are the parents who call at 7 o'clock in the morning. They wake up and their child is dead. And so it's hard to bring back those children, and oftentimes that's the majority of these cases. Then you have the children, these are the drownings, these are the traumatic events, respiratory arrest, and so forth. And then adolescents, which I categorize in the adult group, right? I think adolescents are adults. And so basically, you have these percentages haven't changed in many, many years. And there's a paragraph that you find it at. So what about the adult world? Now, since 2010, I've been a medical director for several agencies, and now I take care of adults, right? So I'm the overall medical director, and one of my agencies, which is Palm Beach County in South Florida, I work with Dr. Ken Shepke, who you guys will hopefully be seeing this year at your conference. But we actually took over this agency in 2015, and we did only a few things. And watch what we did. And by the way, the ROSC rate when we took over was 16%. We did a few things in the adult world. We said stay on scene for 20 minutes for cardiac arrest, right? So there's no moving dead people. And then we said let's do high performance CPR, and we trained everybody up. It's an amazing thing what we do now with high performance CPR. Everyone knows their roles. They come in, There's no speaking. It's just an amazing thing. And then something that Ken will talk about, Dr. Shepke, when it comes to your conference this year is we actually don't provide positive pressure ventilation for the first 6 minutes of a witness cardiac arrest. So a guy goes down, we get there, we put 2 NPAs in, an OPA, we put a non-rebreather, 100% oxygen, and then we start pumping on the chest. And obviously we start pumping on the chest first. And then at the 6-minute mark, then we upgrade the airway to either an ET tube or an iGel. And so with these 3 simple things that I just told you, and we do heads-up CPR, that's for a different talk, but our ROSC rate is now somewhere in the 45% range. So in 1 year, we had our ROSC rate jump from 16% to 45%. And then I said to Ken and the gang, well, what about pediatrics? Why aren't we staying on scene for 20 minutes? Why aren't we doing high-performance CPR? Now, this we would never do in pediatrics, the positive pressure thing, we wouldn't do that. But why aren't we doing these things? And everyone just kind of turns away and kind of mumbles and walks away. And so the problem is not really a medical problem, it's an emotional problem, it's a psychological problem, and that's what we're going to talk about today. And here's the Palm Beach County fire rescue statistics. Florida's ROSC rates. This is our ROSC rates at the start, and here we are at hovering around 43, 45%. And we just submitted an abstract that got accepted, and so we have data. We're publishing all this data. It's been amazing, amazing ride. Now, each of you who are listening today is going to find something very unique and very similar to what this gentleman on your screen experienced. This is Jonathan Robbins. He's a lieutenant, one of my agencies in Coral Springs, Florida. And I want to tell you about his story when he was a rookie. First month on the job, he was in the back of the rescue. They go to a 2-year-old drowning. They get to the scene, and in Coral Springs, it's all gated neighborhoods, all these gated neighborhoods. They drive into the neighborhood. There's a police officer holding a dead 2-year-old right in his hands, and he basically hands him off to Jonathan. And what do you think Jonathan does? He turns right around and he runs right to the vehicle, and he puts the child on the stretcher in the back of the vehicle. And one of the officers who just came off the engine said, "Hey, Robbins, you drive. You're the rookie." Now, Robbins never drove before, but he gets to the front of the rescue, lights and sirens, and they squeal away from the house. He makes a right turn, another right turn, and guess what happened? He hits a dead end. So he turns the thing around, and he passes the house again. The mother looks him right in the eyes as he's passing. He makes a left and another left, and he hits another dead end. And so Robbins passes the house twice before he finally figured out how to get out of the development in Coral Springs. Now, he got to the hospital, and this child unfortunately passed away. And who do you think took full responsibility for this child's death? The guy on the screen. And who do you think he told about how he was feeling, about his negative emotions, about the anxiety and the depression that he suffered over the next several years? He told nobody. He didn't tell his girlfriend. He didn't tell his mother, his father. He didn't tell any of his colleagues. And he didn't make a big mistake, right? He didn't give a 10-fold overdose that killed someone on the spot. No, he just couldn't drive out of a neighborhood. And so it turns out that little events, such as not doing something right, not staying on scene, not performing at a high quality like you do in the adult world, each of you who are listening today, I'll guarantee you that when you have your next pediatric cardiac arrest and it doesn't go so well, you're going to go away from that call asking yourself one thing, which is, what could I have done better? And every time I'm in a CISM after a pediatric call, the very, very first question is, hey, doc, what could we have done better here? And so this is the pediatric care will scar you slowly over time. And when you're young, it maybe doesn't matter, but when you get to 10, 15, 20 years of the same care, it hurts you. And I'm going to tell you at the very end of this talk what happened to Robbins, but I can tell you that it's very scary to me what happens in EMS and all the psychological, emotional trauma. We have to fix it for your emotional health to be well. Now, normally I would have you listen to an audio of a 911 call, and it just won't come through on the go-to webinar, so I'm not gonna play it. But this was a 2-year-old little boy sitting on a toilet bowl, and he suddenly has a quote-unquote seizure, and then he goes into full cardiac arrest. The mother calls and says, "My son is not conscious and he's not breathing." That's the first thing she says. And this is my agency in Palm Beach County. Can I tell you that this lady never got instructions on CPR for her 2-year-old child? And she was waiting, and she was waiting, and the lady almost gave instructions and never did. And I know Dr. Levy has been one of the champions in the country, and we actually copied the no-go that he started and he's using up in Anchorage. But every single pediatric arrest call you should be listening to. Get the tapes, listen to it. So my whole point is here is that in pediatrics, you suffer a lot when your child goes down. As soon as the 911 call is made, most agencies, including my own, don't give parents good, very rapid quality CPR instructions. That's number one. And then we get there, and then it's a whole nother ball game. So this slide in and of itself is to ask yourselves, ask your agency, how good are we doing at dispatch, at the call center? And if you don't know the answer to that, it's very simple. To the audio of all the pediatric and all the adult arrests, and you'll know you'll have your answer within the first 5 calls. I urge you to do that. And that was just a few months ago. This video, I'm going to play it. I'm not so sure you're going to see it so smoothly here because the connection maybe not be that fast. But this is a boy who drowned in a river that you can't see the river. This is somewhere in Bangkok. And these 3 gentlemen are 3 first responders. And I want you to, well, let's see if you can see this. Yeah. Okay, so it's not moving for me, so it's probably not going to be moving for you. So hold on, now I think I'm stuck here. Hold on, apologize. Lizelle, can you still hear me?
Yeah, I can still hear you, Dr. Antevy.
Because my computer. Just give me a second. Let me do this, and I'll try and start it one more time. Okay, here we go. Lizelle, is that video even coming through at all?
Yeah, it's coming through. It's good.
It's probably coming through spotty. So look at what they're doing for this kid. So the reason I'm showing you this video, and I'll talk over it here for a second, the reason I'm showing you this video is because this is what would happen if 911 phone call was not available. You would have people doing anything, something, and what they're doing here is absolutely ridiculous, right? You're probably looking at this and saying, he's putting him over his shoulder, he's taking a lap, there was no chest compressions being done, they're not breathing into his mouth, they're doing none of that. But this is what happens when you don't have a coordinated system of people telling you what to do. But I'll ask you, is this better than what happens in my counties in South Florida, where most of the time my medics get to the scene before the parents have started CPR? And that's really the question I have for you as you watch this. Which is better? And then how many of you think this kid's going to make it? Let's take a look. Focus here on his eyes. Again, it may not be coming so good on your end, but right there he starts blinking. And now he's breathing. And so, as crazy as that was, it turns out that it almost doesn't matter what you do as long as you do something. And I kind of joke that in America we say 15 compressions and 2 breaths. In Bangkok we say 15 compressions and 2 laps. That's what they do. And they were so excited about it that they posted it on YouTube. Now, if I would have started that video again, you would have noticed that the guy without the helmet, the guy who did the laps, he unbuttoned his shirt right there because these people have done this before. They've saved children before. So it turns out that all this, how many inches you have to push and how many breaths and how many this and how many that, it probably all doesn't really matter early on. And so the earlier you can do something, anything, is probably more important. But in America, what we do is we say, call this 3-digit number, and then we'll give you permission to then do CPR on your child. Where did that come from? Why do we have to call somebody to get permission to do CPR on our own children? It turns out that parents don't even give CPR to their own kids. And so we have a very big problem, folks, in America, which is parents don't do CPR, number one. They make a phone call to get help, and we don't do it. And then minutes go by, and then we show up, meaning EMS, and then it's a whole nother problem. So instead of fixing what happens in the hospital and all the stuff, we have to fix the easy stuff, which is getting lay people to do CPR, getting the call takers to get on the chest, to get the people on the chest very fast, and then when EMS gets there, we'll talk about that next. Here's a lady in Miami, right on I-95, the main highway here. Her child, or I guess it was her, I think it was her niece, it turns out, turned blue. She didn't call the 911. She just stopped her car on the highway, got out of the car, and some bystander took this picture. All the traffic stopped on I-95. She is right in the middle of the highway doing CPR. So what do we have to do today to make this happen is my question to you. And again, I don't have the answer to that. I wish I did. I'm working on it. But I think it's a local thing. It's a regional thing. What you guys do in rural Alaska is very different than what I do, where I have a hospital within 5 minutes of anywhere. It's very, very different. So it's going to be local the way that you do that. So I'm going to get your blood boiling a little bit here. I'm going to give you this call, which is a 5-year-old female, difficulty breathing, ate food cooked in peanut oil. And I'm going to tell you, you're going to be showing up to an anaphylaxis call. So as you're thinking of that, your brain just took you somewhere. I'm going to stop you for a second. And then I'm going to say you have a 6-minute arrival. Now, what if I say stop? That's not a 5-year-old, I lied. It's a 65-year-old with anaphylaxis. Where does your brain take you now? And I'll bet you that when I put up the 65 instead of the 5, you said, no problem. That's a simple one. But when I put up the 5-year-old female, your emotions went to a whole nother. Now, why did that happen? How did we convince you, and who convinced you? And I'm saying this rhetorically because it's the establishment. How we've trained you was 5-year-olds are different than 65-year-olds. Someone convinced me of that years ago, and someone convinced you of that, and we have to undo that. So look, let me take the 6 back away, and here we are back, and here's your patient. You show up, and you have this. Now you're nervous, you're anxious because you had, let's say it took you 6, 12, 15 minutes to get there, whatever it was. I'll bet you that there are very few people, and I don't know anyone who can do this, but who know all the dosages for a 5-year-old female for epi, Solu-Medrol, Benadryl, normal saline as a volume. Not many people can tell you the dosages of those medications. So what did we teach you? In pediatric, you shouldn't start making your treatment decisions until you get there. But for the adult, for the 65-year-old, when do you start making your decisions? Right when you hear 65-year-old anaphylaxis, you say to yourself, 0.3 to 0.5 cc's of epi, IM lateral thigh, no problem. Solu-Medrol 125, easy. Benadryl 50, easy. Liter of saline, easy. Albuterol, Atrovent, easy. And as you're going to that call, you go through that process in your mind 1,000 times before you even get there. In pediatrics, we tell you, don't think of anything. Stress out, stress out, stress out. And then when you get there, now you have to face mom and dad. And then we say to you, take out a measuring tape. And then we say, start doing the mathematical equation. So, you have to understand that people put things in place thinking this was a great idea, right? They put lights up on this dark road, and they told you, we're doing you a favor. But are they? They're not in your shoes. They're not doing you a favor. Here's another kid, and this kid's seizing. and the parents are nervous, right? Seizures make everybody nervous. Whatever reason, nurses get nervous, doctors get nervous, everyone gets nervous. If you're going to get to this scene without having your A game on and looking at the parent straight in the eye and saying, I'm here to help out, tell me what's going on, and let's get the medication on board. If you can't do that confidently, you're not going to do it. And it's just as simple as that. There's no taking another class to teach you that. And if you had 20 seizures in a row of all different ages, each time you go to that seizure, you're going to have the same exact problem. And that's the problem. Lizelle, can you guys still hear me okay?
Yes, perfect.
Okay. So now I'm going to give you another case. Here's a house fire, and you have the house is burning. They pull out a 61-year-old male, unresponsive, full cardiac arrest, and then someone says, you know what, nothing's working, let's try this. And what's the this? I'm sure you're saying this, but I just can't hear you. It would be a cyano kit. But what if I told you now they bring out a baby with the same exact problem, full cardiac arrest, and now I say to you, you know what, we have to give this kid hydroxycobalamin. Now what are you going to do? So here's another thing where for the adult, you just mix it up and you give the whole thing wide open, fine, easy. But for pediatrics, it's a whole nother ballgame. And so there are differences in pediatrics. So let's kind of drill down into this emotion. I've kind of put you in several emotional states here in the last couple of minutes. Now I'm going to explain to you why that all happened. And I'm going to do that by talking about this amazing book. If you don't want to read the book, just Google this guy's name or listen to, watch the YouTube videos. But I'm going to basically talk to you about his principles. This is Daniel Kahneman. He's a Nobel Prize-winning psychologist. And he writes this book called Thinking Fast and Slow. It's got nothing to do with medicine, by the way. He has a couple of stories in there about doctors and firefighters and so forth, but it's not a medical book by any means. The purpose of the book is that he tells you your brain is hardwired to think certain ways. Your brain is hardwired to make mistakes. And so I'm going to explain to you what he says. I'm going to give you some problems that you're going to make mistakes. You have no choice but to make mistakes because, like he says, your brain is hardwired to do certain things. So let's look at that in more detail. So Kahneman talks about the very fast part of your brain called System 1, and then a very slow part of your brain called System 2. Fast part of your brain is a part of your brain when, let's say I tell you not to answer the following question. Don't answer this question. 1 plus 1. Well, guess what? As soon as you heard it, you answered it. Because your System 1 is very fast, and it's very arrogant, by the way. It's very cocky. And it thinks it knows everything. It's always going to answer a question that it can't answer. When you're driving down the road and someone cuts you off, and you veer out of the way really quickly, that's an automatic response. You didn't think about it, you just did it. That's System 1. When you walk into a guy's house and he's 60 years old and he's got chest pain, he's diaphoretic, he's clutching his chest, you aren't thinking about, the algorithm. You automatically know exactly what you're going to do. You automatically know what medications you're going to give. You know you're going to throw a 12 lead on this guy. You know you're going to transmit this 12 lead to the local hospital right from the guy's house. This is not stuff that you have to remember. It's automatic. System 2, on the other hand, you have to wake it up and ask it a question, and it'll have to do you a favor to actually answer it. It's very lazy. It's very slow. And it's sleeping most of the time. So I'm going to explain to you why in the adult world, all your adult protocols are System 1. And I'll prove to you in a minute that your pediatric world is all System 2, and that's really the crux of the matter. Let me explain what I mean. If you've never seen this image before, as you're looking at it, your brain is trying to tell you that one of them is longer than the other. For those of you who have seen the image before, you know that these are exactly the same length, these lines. And the trick is that when you have arrows pointing in different directions, it tricks your brain. And so your System 1 wanted to make the mistake, and maybe it did, but the cool thing is that the next time you see this line, these two lines, you'll never make the mistake again. So your System 1, it made the mistake, it learned from it, And next time you say, ah, that guy tricked me last time, I'm not going to get tricked again. So great. So system 1 is very fast. But for those of you who saw it for the first time, you probably said, ah, the top line is longer. Okay, next one. System 1, when it comes to pediatric assessment, when you walk into a home and a kid looks at you, your brain tells you automatically sick or not sick. So I'm going to test you. I'm going to put up an image, and then as you're watching the images come in, without even me asking you, your brain is telling you exactly which kids are sick and which kids are not sick. And it takes all about like less than 0.1 seconds. There was something about these kids, we can go into the fact that he's got retractions or the eyes are closed, whatever that it was, your brain didn't even need that. It just knew that the kid was sick. So here's where your system 1 is very, very good. If you guys take the PEP course, you know, the PAT, what we call the Pediatric Assessment Triangle, all that is your system 1. You walk in the room and your gut feeling is sick or not sick. That's a system 1 assessment. It's very good at that, so trust that instinct. And then sick or not sick, is my favorite one. This is Charlie Sheen. Yeah, he's very sick, but he's still alive, and we got to give him credit for that. All right. Now, if you've never seen this question before, try to answer it. And again, I can't hear you guys, but I know that most people say one of each kind, or they say two. But for those of you, maybe one or two of you got this right. It wasn't Moses. It was Noah. And so your system 1 basically saw I hear the laughing. It's good. That means you got it wrong. Well, but I would say about 95% of people get this wrong. And some people will keep looking at it for a few minutes and they'll still never get it right. And it turns out that your system 1 sees a biblical name, it swaps out Moses for Noah, and it answers a question that wasn't really there. And so the point of this slide is that you are making mistakes. Not you, we in healthcare. I personally have made many of these Moses illusion mistakes. Why? Because you don't even know you're making them. So you could give someone an overdose or an underdose for that matter and never know it. You can go home and say, oh, wow, I did a great job today, and no one ever knows that you gave an overdose. And I'm going to prove that to you here in a second. So if I show you these two tables, which table is longer and which table is wider? Now, most of you are saying that table A is longer and table B is wider. But what if I told you that table A and B are the same exact length and width? You're probably saying there's no way. Look it up. These are images that have been used for many, many years. It's not me making this up. What Kahneman says is that your brain is hardwired to make mistakes. System 1 will tell you this is longer and this is just shorter and fatter, but they're not. These are the same exact length and the same exact width. Trust me, this length here and that length here are the same exact. That here and that here are exactly the same. It's a visual optical illusion. System 1 error. And your brain, it turns out, your system 1 is sitting right in here. This is your primitive brain. This is back when we were like, lizards. Who knows what we were back then? This is the part of our brain that is our gut instinct. And this is the part of your brain that you are using for that gut instinct. This is the part of your brain that, is kind of the more cerebral part of your brain, the part of your brain that you kind of use higher form of thinking. And so it's what I call the Homer brain, Homer Simpson brain. So why is that important? It's important because when your brain sees these 4 images and I say to you, who would you vote for the next president of the United States, who would you pick? And I would say that most of you who are looking at this will pick that guy right there, because your primitive brain is telling you that this guy looks more trustworthy, that this guy has facial features that maybe look like someone that could be your next president. And so a lot of the decisions that you make on a day-to-day basis are based within your primitive brain. And so your system 1, as good as it is, in the medical field, it'll make mistakes. And let me give you a better example of that. So what do you see on the screen here? You see 12, 13, 14, right? Okay. Well, what do you see here? Now you see ABC. But what you're noticing here, and I'll put them both up on the screen now, is that that middle image was the same. Your system 1 was able to see numbers and make that a number, to see letters and make that a letter for you. You didn't have to do it, it did it for you. So system 1 is very fast. Now, I just started doing this little trick about 3 weeks ago, and it's very, very simple, so I'm going to try it on you guys. I'm going to give you a series of 9 numbers, easy numbers. These are not very difficult numbers. And between every number, you're going to have 1.5 seconds. I want you to count up all those numbers. And at the end, and again, maybe you'll, you know, do Lizelda, maybe we'll have them type in the, just to make sure that they're awake. Type in the chat bar your answer, and then I'll give you the answer afterwards. But this is not a trick, folks. It's not a trick. But this is what happens on scene when you're adding things up and you're doing math. Let's see if you can do that with some very basic and simple numbers. Here we go. Okay. Okay, I'm going to stop.
Okay.
And now I'm going to wait for some people to type some things in here. So those who are listening.
Answers are coming in. So we have a bunch of things: 6,000, 5,100, 6,000,
Okay.
6,000 in the classroom. What do we have?
5,100.
We've got a 6,000. We've got a 5,100.
6,000.
We've got a 6,000. So it looks like 6,000. There is a lag for me, so I couldn't see the numbers. Oh, sorry.
Okay. Okay. So would you say that a majority of people pick 6,000?
Correct.
Okay. And I hate to say this, but they're all wrong. And let me show you. Let me show you exactly what happened here. So I'm going to bring it up. Now do that one more time. Try and count these now. Take your good old time and count it up again.
Oh.
Do you see what your brain did to you?
Yeah.
Your brain took all the 30, the 20, the 40, and the 10, and it made it 300, 200, 400, 100. And so you're looking at it now and saying, how could that be? Like, how, you know, this is so darn simple. But I'll bet you that if I were to put those numbers up again and say, hey, you know what, count that again, you would have gotten a majority of the people to say 6,000 again. And they would say, why are you asking me that again? I got it right the first time. They don't even know that, they won't even know that they made a mistake. And so the answer is 5,100. Whoever said 5,100, very good. There's always a few people in the room who get it. But this is system 1 error. And it's so easy to do the math, but it's not so easy to do the math, it turns out. And so this is an amazing view into your brain to show you that when you're on scene and someone says, hey, how much midazolam do I give? Well, I don't know. How much does he weigh? I don't know, 25 kilos. Okay, 0.2 per kilo. And then you give a number that you thought was right. And by the way, when we document, and I know my medics document an hour and a half later, sometimes they'll go back into the protocol, do the math at the station, and put the number in that they were supposed to, not the number that they gave. And so this is amazing right here, that your brain is hardwired to make these mistakes. And so that's a problem. Now, let's move into System 2. System 2 is like I told you, very different. Now, I'm going to put another math problem on the screen, and I want you guys to answer it really quickly. Ready? And go. So as soon as you see that question, your System 1 checks out. It says, I'm done. I'm going to try. Right. Now, if I was standing in front of you, the people who are actually trying to do this, your eyes are going to go up and to the right. Kahneman will tell you your eyes will dilate, your heart rate goes up. But I will bet you that, and when I do this in a live audience of hundreds of people, and I say, be honest, how many people tried to do this? Very few people raise their hand. So we are trained that unless we really, really want to do the math, we're not going to do the math. We're just going to stop and say, you know what, I'm not going to do it. And so, and when you have a dead kid in front of you, or a kid with severe pain in front of you, or a seasoned kid in front of you, your brain says, I have two choices. I can sit here and struggle really hard, or I can just leave. I can just take this kid and leave. And that's exactly what your brain does. And so let me explain. So the NIH stroke scale is another system 2 thing. Nobody in the world can walk into a stroke patient and say, yeah, you got a stroke scale of 16 or 7 or 2. No. It's a system 2 process. Here's another one. This is my favorite one. If you ever drop off a sick patient to your local hospital, a pediatric patient, stay in the room for a couple of minutes. Be a fly on the wall. Now, I'm going to make believe I'm the doctor, and I'm going to say, okay, 2-year-old septic patient, I'm at the head of the bed, and let's say I say to my great nurses who I work with, which are great, and I say, can I please have a central line? I'd like to start a norepi drip. I would like to intubate this patient, get a Foley, an NG tube. What do you think they're going to say back to me when I say question number 1, get me a central line, please? What they're going to say right back is, well, what size do you want, doctor? Norepi drip, please? Well, how do we mix that? At what dose do you want to start? What rate do we start the pump at? I don't know any of those answers. I had a kid recently who got shot in the chest. By the father, by the way. He was doing drugs. He shot through his own wall in his house, and he hits his 5-year-old son in the chest. They don't call 911. They rip off all his clothes. They drive into the hospital, and they run in with this naked 5-year-old bleeding everywhere. I walk into my trauma room, into my trauma bay, and one of the first things I say is, I'd like to have a chest tube, please. And now, fortunately, we have our system in our hospital, but the last thing I wanted them to ask me was, what size chest tube? Because I don't know. I don't put chest tubes in kids all day long. I'm lucky if I put a chest tube in a kid twice a year. So what happens when we ask system 2 questions? The same thing that happened to you when you saw the 24 times 13. You say, I'm checking out. I'm not doing it. And what happens is it becomes not fun anymore, and it becomes dangerous, and that's what happens. And Kahneman says that when your system 2 gets stressed out by dosing, mathematical calculations, drawing up medications, and your system 2 gas tank goes to empty, as soon as your system 2 gas tank goes to empty, this is what happens to you. This is what happened to me. This is what happens to paramedics, but paramedics can do something when they feel this way. What do? I know, because now I'm an EMSer, right? We leave. Diesel fuel. We load and go. We are very good at telling the parent, we have to get your child to the hospital. Now, in the ER for many years, and I'll admit it, I would leave the room. I would walk into a room, the kid's sick as shit, and then I would like slither out of the room. And the nurse would come back and say, where the hell did you go? Get back in there. And I started to realize that they were asking me questions I didn't have the answers to. And no one ever told me that these are system 2 questions, that maybe I wasn't supposed to know these. It's impossible to know all the answers to these questions. And this is really the problem. And it took me years to figure this out. And now that I figured it out, I feel so much happier because, I thought that I was just, maybe stupid. How could it be that I didn't know? I trained in LA, I trained in Pittsburgh, I worked in Boston, I worked in Philadelphia. I was supposed to be the guy who knew everything, and it turns out when I came to work as a real doctor 11 years ago in Florida, they thought I knew nothing because they asked me questions that I didn't have the answers to. And the same thing happens to an EMS provider. And it's unfair, and it should not be allowed, and that's really what we're working to change. So if I tell you today that you're going to have your very next call in 30 seconds from now is an adult cardiac arrest, I'll bet you that you feel like this, right? Bet you. All of you listening today, you are going to rush to be the first one to that scene. But if I say, okay, pediatric cardiac arrest, then you feel like this, right? So what is it that happens? Is cardiac arrest for adults different than cardiac arrest for children? Is hypoglycemia for adults different than hypoglycemia for children? Is seizure for adults different than seizure for... No! It's the same exact algorithm. It's the same exact algorithm. But someone has taught you that adults and pediatrics should be treated differently. Someone has told you to take an ACLS course, and then next year we're going to do a PALS course. And those are two different things. And you got to pay two different costs for that, for those little cards that they charge you for. Why? Right? It's not true. At the end of the day, it's not true. And so I'm gonna test you again. 60-year-old male. He's unconscious, but he's breathing. He has a pulse. You get there. The blood sugar is 18. You have an 18 gauge in his right AC, and you have to give D50. How much are you going to give? Now the guy goes into cardiac arrest. You have 1 to 10,000. How much are you going to give? And then a mild allergic reaction, you want to give Benadryl. How much are you going to give? I'll bet you that all of you said, without even blinking an eye, we're going to give an amp of that, an amp of that, and we're going to give all of that. And so it's 50 ml, 10 ml, and 1 ml. Easy peasy, right? So now, as soon as you fix this guy's 3 problems, his 5-year-old grandson has the same 3 problems. Go. Right, so what's the volume of dextrose? What's the volume of epi? What's the volume of Benadryl? You're probably saying to me, oh, okay, well, now how much does the kid weigh? Well, I don't know, we're not there yet. We have 6 minutes to get there. So you see the problem? On the last case, you knew the dose right away, just by hearing the age. But on this case, you don't know the dose because you don't know the weight, because you're not there yet, and we give you a measuring tape, and then there's more calculation. So I'll be nice to you. I'll tell you that the dose that you need for this kid is 10.5 grams. Now, did you get D50, D25, or D10? What does your protocol say? Well, your protocol probably says D25. Well, you don't carry D25. Okay, now we got to make it. And I got to make D25. Now, if I tell you have 50 cc's of D25 here, what's 10.5 grams? Ah, that's another math calculation. And the calculation is 10.5 divided by 0.25. Right? Is anyone with me yet? Right, it's impossible. It's impossible to know that math equation. I don't care who you are. The answer, it turns out, is 40 mLs of D25. Now that just seems impossible, right? There's no paramedic I know who will do that on scene more than once. Because the first time is so difficult and it's so painful, you'll never do it again. Same thing for epi. Epi's a little easier, and Benadryl's really hard too. So here we go again. It's all system 2. So here's the moral of this story, is that all of pediatric treatment, I don't care if it's Motrin dose or Tylenol dose or adenosine or epi or Benadryl, Solumeldrol, normal saline, equipment sizes, I don't care, it's all system 2, which no one should have to do on the scene. But for the last 30 years, you go to a PALS class, which, by the way, I have a PALS course as our training center. We do over 1,000 people a year. And trust me, I've been to enough of these courses that I can recite it by heart. And it's painful to me to see what we do. We show them videos, then we bring them around a table, and we say, here's your 2-year-old patient. What are you going to do? Oh, yeah, I'll give epi. Okay, how much epi? 0.01 per kilo. Okay, good, great job. Let's switch it up. And that's what we do. And you leave there not any better at System 2. You cannot learn System 2. You can't go home and do math better. It's got nothing to do with it. We have to remove it altogether. So, to conclude this section, and then maybe I'll stop for some questions if there are any. System 1 is very fast. It's amazingly fast, but you'll make mistakes. And I can give you those examples that I gave you where you made mistakes. I have 100 more of those. And you'll get all 100 of them wrong, or maybe at least 95 of them wrong. System 2, very good information resource, but it cannot function during stress. And so we don't want System 2 around when we're resuscitating a child. We want System 1 to be there. So we have this dichotomy of this is very good in the adult world, this is needed in the pediatric world, but we don't want to have System 2 during resuscitation. So I'm going to pause there to see, are there any burning questions at this point in time or comments, or should we keep just moving on?
Yeah, give me a second. So anybody in webinar land, do you have questions? Now's your time. I had a gal that was sitting in the class and had a question, but she just stepped out.
No,
Oh, wait,
no.
no questions so far, so.
Okay, either everyone's sleeping or everyone gets it. Okay, good.
It's still showing.
All right, awesome. So
we're good.
okay, good. All right, so we're, this type of information that you're seeing on your screen has been known for a long time, that medical errors happen. We make medical errors. There's not one person who's sitting here today listening to this, including myself, who hasn't made medical errors. I've made them. I've been embarrassed by them. I've learned how to talk to families about them afterwards. And I have lots and lots of medics, and we see lots and lots of patients in all of my EMS agencies, and we still make mistakes. So these mistakes are happening. Why do they happen? Well, here's why they happen, right? This is vasopressin, and this is Zofran. 2 o'clock in the morning, you may pull out the wrong vial, and I can tell you that they're, locally in my area, we have given amiodarone to children instead of Benadryl, and it happened twice in the last 6 months. We've given fentanyl instead of midazolam. Don't ask me how that happened to an adult patient, but this is one of the reasons why. Here's another good one. Here's oxytocin and Reglan. Here's Ancef, an antibiotic, and vecuronium, a paralytic. This was a child who they wondered why wasn't breathing after he got his antibiotic dose. Well, he didn't get antibiotics. He got vecuronium, and a lot of it. And so medical errors happen because those are System 1 mistakes. This was an article published this year by Dr. Paul Rosticus up in Oregon. And you can see here that he looked at EMS protocols for hypoglycemia around the country. And what did he find? He found that there was no consistency at all in the dosing for pediatric patients. And that you could see here that basically every agency's protocols said something different. One said use this dose, that dose, D5, D10, D25, D50. It was all over the map. So not only is this stuff difficult, but we're not doing it the same anywhere, right? Everyone has a different way of doing it. And I'm not sure what your protocols say, but a lot of agencies now are moving to D10 for everybody, which is what I like. But it used to be D50, D25, D10, very, very confusing. So we're not making life any easier for anybody here. Now, we've talked about resuscitation quite a bit. Now I'm going to take you to the bread and butter. Now, this is the part where if you're sitting in the room, you're going to get very angry. And I'll show you why you're going to get angry. Here's 3 very simple cases. And these are more than likely the medications that you use at your department. If it's not fentanyl, it's morphine. But usually most of us use midazolam. And so this is not resuscitation. This is bread and butter pediatrics. Epi, fentanyl, intranasal, midazolam, or fentanyl. Remember these 3 drugs. And now let's take a look at the length-based tape, which is, of course, the Broslow tape. And I will say that Dr. Broslow is a great man. He's done amazing things for the field of pediatrics. So I don't want you to take this as a knock against him. But this is 30 years later. And look at these 3 drugs. Epi 1-to-1, fentanyl, and midazolam. If you want to have fun tomorrow, take your Broslow tape, go to one of your medics and say, hey, we got this kid stung by a bee, and he lines up to the blue. How much Epi should we give this kid? IM. And I guarantee you, please email me if this doesn't happen, that a majority of people are going to just look at the tape. If you put them in a stressful environment, look at the tape and say, oh, Epi 1-to-1, 2.1 milligrams, 2.1 ml. And then you're going to say, okay, now what if it was a 60? And they're going to say, 0.3 milligrams, 0.3 mLs. And you're going to say, and how much for this 5-year-old? 2.1 milligrams, 2.1 mLs. And then you're going to have to stop them for a minute and say, listen to what you're saying. Adult 0.3, but this is 2.1? So it turns out that this is not the anaphylaxis dose of Epi. This is the resuscitation dose of epi down the ET tube. There is no anaphylaxis dose. I made this mistake early on in my career. Okay? Fentanyl, pre-medication for RSI, 63 micrograms. So this is not the pain dose. This is 3 to 6-fold higher, depending on what your protocol says, of fentanyl. If you give this dose of fentanyl to somebody who's in pain, their pain will go away, and so will their respiratory effort, unfortunately. Midazolam, it's an induction agent. In this particular case, this is not the seizure dose. On the other side of the tape, under the seizure section, it doesn't say midazolam. So the only midazolam you'll find on the tape is this dose, which is a 3-fold overdose. People will stop breathing with this dose of midazolam. And so I told you about resuscitation. Now I'm taking you to bread and butter, pediatrics. What about Benadryl? That dose is not on here. Salumedrol, that dose is not on here either. Zofran, not on here. Albuterol, not on there. Atrovent, not on there. So here we are in 2016. We have every agency that we work with has anywhere between 20 to 30 medications that they use for pediatrics, and the majority of them aren't even on the tape. And then we make you do math, and you do math and it's wrong math because these doses are way higher. And then when you make a mistake as a medic, we come back and we slap you on the wrist and we say, ha, it's your fault, medic. You know, nobody else would have made that mistake. And instead of telling them, hey, it's not the right dose, you just go back and you feel bad about what you did that day. This is not right. It has to change. And then you have people who publish papers like this. This was just published last quarter. They looked at the total number of patients, and this is in Costa Contra County, which is in San Francisco. And they see a lot of patients up there as EMS patients. Of those 240,000, there were about 100 kids in pediatric anaphylaxis, true anaphylaxis, meaning they had 2 organ systems involved. How many of those patients do you think got treated with epinephrine? Let's take a look. 53. And then epinephrine withheld 45. But when you look at the 53 given, only 6 of those were by EMS. And then of the withheld, and these are all EMS-only patients, they gave albuterol, they gave Benadryl, they gave both, and then some got nothing. So then people come out with these studies to say, look at these paramedics. They have these obvious cases of severe anaphylaxis, and the paramedics just don't want to give epinephrine. Well, no, that's not the reason. The reason is because the dosing that's on the tape is incorrect. The Benadryl dose is not there. The Salumedrol dose is not there. So over time, the paramedic says, you know what? I'm not sure what all this is supposed to be here. I'm just gonna do nothing. And my medics do the same thing. In this study, only 11% of patients that EMS could have given epi to, they gave it to. So the takeaway is not that the medics don't know what they're doing. It's that the system that they're working within is completely bad for them. The system doesn't work. That's the take-home message for me. And when I looked at my protocols in Broward County, which is similar in Palm Beach, and I compared it to the length-based tape, I said, wow, could it be that everywhere there's a red box with empty, that doesn't exist on the tape, and everywhere there's white writing in the red box, the medication name is the same, but the dose is way off of my protocol. And so we found a 50% discordance between the protocol and the tape. And these are all Moses illusions, right? These are all dosages that you would say, I would get there and say, epi 1-to-1, yep, there's a dose, and then somebody would have to tell you later on that you gave a 10-fold overdose. You'll make the mistake and you won't even know it. So we ended up doing, I said, you know what, let's take a look and do a study of many EMS protocols. And we looked at small population, large population, we looked at everybody. And you can see here what we found. Our data suggests that there was a 49% discordance across the board. Meaning that if I took your protocols today, and I'll be very happy to do that, I have a whole team of people in the office now will do this for you guys. Send us your protocols and we'll send you what your discordance rate is. I'll bet you it's in the 40+ range discordance, because that's what they all are. We've had some as high as 63%. The folks in Minnesota, North Memorial, had a 63% discordance. That's not fair to you as the provider. It's not fair to the patient, and then at the end of the day, it's not good for our department as a whole. More data. This is a group out of Texas and Colorado who basically looked at the evidence-based guidelines that exist today for pre-hospital care, for seizure, hypoglycemia, you name it. There's 26 medication recommendations, and then they compared that to the Broslow tape, and they found something staggering. They found that only 15% of these 26 medications were listed correctly on the Broslow tape. 54% not listed at all, and 31 were listed incorrectly. So, finally, I've been saying this for many years, and finally other people are coming on the bandwagon and saying the same thing. This is system 1 error all day long. There's finally a study looking at our system and our way of doing things. We were not involved in the study. You could see the error rate was significantly higher, 3 times higher with the length-based tape. So, and there's a lot of other studies out there looking at why paramedics make mistakes, and they'll blame the paramedic. But if you look at all these reasons here, you can't figure out the weight, you can't use the tape, you make errors calculating. These are all system 2 errors. So if we remove system 2 completely and we say, just treat these kids like you would treat adults, maybe that's the solution. And so this is another study that was just released. Literally, I got this magazine in my mail 2 days ago, this journal, and I sat there, my mouth was gaping wide open. I'll show you the data in a minute why this is. These are people, very smart people. By the way, this was done in Houston, and the reason I'm in Houston for the next 2 days is because we're going to be getting Houston Fire Department to convert over to our system. Well, lo and behold, this simulation study was done in Houston on the Houston Fire Department, and I said, wow, let's take a look at what they found when they put. They took. I'll show what they did here. This is very cool. They actually they had 2,200 seizures in Houston between 2011 and 2013, and so they whittled it down to about 250 seizure patients. These are real seizure patients. They took half of their medics and they said, we're going to put you through this very intense course called the STEPS course. We're going to teach you medication dosing and algorithms. We're going to make you a pediatric seizure expert. That's the trained group. And then the control group was the people who just did, regular stuff. They went to the regular course. There was no specific training. And then they said, let's take a look at how our medics, after an entire course, just like another type of course, let's see how they did. So, as I was reading this article, I said, well, let's take a look at what they found. So, let's take a look. So, here are the non-trained paramedics and then the trained paramedics. So, did they check the blood glucose? 72% checked it. 66% of the non-trained checked it. Did they give midazolam if the patient had a normal blood sugar? 63% and 56%, so basically equal. And then did not give midazolam, a very high number in both sides, 27 and 34%. So it shows here in this one diagram here that extra training didn't help them. But here's something even more interesting. So here are those who received the first dose of midazolam. 58%, so only 58% of children received a first dose of midazolam. So just a little bit more than half. And it turns out that, it didn't matter if you were trained or not trained, but let's take a look at the next one. Was the correct dose of midazolam given? And it turns out that only half of the dosages that were given, it didn't matter if you were trained or not trained. Sure, they gave it in this many, but half of them got it wrong. Half of them got it wrong. Now go back to that, what I told you earlier about midazolam, because it's wrong on the tape. So this was fascinating to me that they're teaching people to do something, and nothing changed, and mistakes were being given at an alarming rate. And look how long it takes people to give midazolam, up to 15 minutes. Okay? Shouldn't be that. So this was an eye-opener for me, I must say, in many different respects. So I'll be interested in talk to the actual people I'm meeting with tomorrow, or some of the authors on this paper. So it'll be interesting. So what happens when we get this call? We have 6 minutes until we get to the scene. I'm sure with you it's a lot longer in most places. You're on the scene for 12 minutes, and then you leave the scene and you get to your local hospital, I'm sure a lot longer than 8 minutes. So if I'm telling you that we're not treating on scene, we're departing the scene and we're doing CPR that's not really that good, because we should be doing CPR where we find these kids, I'm telling you that we're not treating appropriately kids in cardiac arrest, and we're bringing children to the hospital who are dead. And if you bring dead kids to a hospital, one of two things is going to happen. They're going to stay dead, or they're going to have significant neurologic deficits, and they'll be on a ventilator and a G-tube and a trach and so forth for the rest of their lives. And so we have to really take this entire process that we've done and turn it completely around and change it completely, because these are the two boxes that we have to work on. We own these two boxes. We're very in touch with our community, because that's what we do. We're first responders. We're all in our communities. We own dispatch, and we got to take the Mike Levy regimen of no-go and blast it across the country. And then we own this box right here, this on-scene box. So what I'm trying to say to you is that pediatric care and the outcomes in pediatrics sits with us in EMS. It doesn't sit with the doctor at the hospital or the specialist in this. No. Outcomes in pediatrics, when I'm talking about the critical outcomes, we have the biggest impact, especially in cardiac arrest. And so think of how many patients, pediatric patients today in Alaska, get epinephrine prior to arrival at the hospital. Now you're probably saying to me, hey doc, that's a no-brainer. I'm sure all of them are getting epi. If I said to you, how many of your adult arrests are getting epi, you would say, well, it's a stupid question. Of course they're all getting epi. But I'll challenge you on that, and I'll say that we did some data searching. In Florida, only 32% of children in cardiac arrest were getting epinephrine. In Colorado, 28%. And in one city in the northeastern United States, none of them were getting epinephrine. Zippo, nada. And that was in 1 year. So I was taken aback, and I said, I have to do a national study on this, and that's what we did. We looked at 20 million records. This was very, very hard to do. The Nemesis data set is very dirty. It's not a good data set. Anyway, don't tell them I said that. 1,465 patients, and guess what we found? Only 34% of those patients got epinephrine. So the proof is in the pudding here, folks. We're not treating on scene. We're not giving the correct dose, or we're not giving correct dosages, and we're not even giving dosages, especially when it matters most, which is in pediatric cardiac arrest. And so I'll prove to you that epinephrine early works, right? Some people say epi doesn't work, is what people say. Well, I disagree. I think epi, if you're going to give epinephrine to a pediatric cardiac arrest, you have to give it within the first 10 minutes of arrest. So if the arrest happens right now and it takes you 6 minutes to get there, well, guess what? You have 4 minutes on the clock to get this kid, quality BLS, good CPR, an easy IO if you carry that, and then give your dose of epi, and you have to do that very, very fast for epi to even work. And you can see here, early epi, good outcome, late epi, bad outcome. Here's another study in pediatrics out of hospital. This is in hospital, sorry. Early epi, good outcome. Late epi, not so good outcome. Here's a great one. Just read the title. Time on the scene and interventions are associated with an improved survival in pediatric out-of-hospital cardiac arrest. The answer is in the title. And believe it or not, the best outcomes, survival to discharge, was the highest when? Oh my goodness, it's exactly what we do for adults, in the 25 to 30 minute range. So here we go again. Staying on scene for dead kids is what we have to do. We know that, but now we just have to give you the tools to do that. Because I can't just tell you, all right, the data says that, or Antevy says to give epi early, blah, blah, blah. If you don't know how to do that, then you're never going to do that, and it's going to be a problem. So please, I'm begging everyone today, and I'm going to teach you how to do this so you have no excuse. And so you will leave today knowing the dose of epi, amiodarone for dead children, and you'll say to yourselves, my God, I can do this, and you will get kids back, I'll guarantee it. But it's happening. We have the data now. Now I can say that emphatically. A few years ago I would have said, I think so. Now I say, I know so. It's 100%. So in Michigan, they did this data set. 5 million records, 266 arrests. But look how much time they stayed on scene for pediatrics versus adults. In pediatrics, it's basically load and go. In adults, they'll stick around and they'll do the right thing. So let's talk about what to do. I think I've laid out the problem, and you can see that I can get, that I get very intense and emotional about this stuff. Because I think that I think that there's a lot of good we can do if we just do a couple of small things. And let me show you what I mean. I want you to go from scared Shaggy to happy Shaggy, and then maybe not to big Superman, Superwoman, but like mini Superman, Superwoman. And I'll get you there. How are we going to do that? We remove system 2. So let's now take this from a problem to a solution. So here's where I differ from a lot of people. Where they tell me to use a length-based tape, I say no. I want to start with age, just like I do for the adults. I want you to do for kids. Yes, I'll have a length-based tape as a backup, but I'm going to use it only 5% of the time, only 5%. So this is not in the guidelines today, but I guarantee you that I'm going to make that happen. Okay, you can just put it in the books because we have the data now, and I'll show you one paper in a minute. No math. You have to be in a system where there's no math being required. If you're doing math on scene, you're in trouble, and that's where the mistakes are going to be. Remember the 6,000 and the 5,100. You're going to do math that you think you got right, but you didn't. The equipment, you have to know what size before you get there, and you shouldn't be like having to go look up the size. It should be open this pouch and it has what you need in it. And then what we do for the agencies that are using our system is that we say, okay, here's your medications and your protocols. I'm going to give you a case, and I want you to draw up your dose for your agency. Not the dose that the PALS tells you. If Dr. Levy says we use D10, and for a 5-year-old the dose is this, we're going to take the D10 out, we're going to get a syringe, we're going to pull out the volume, and we're going to watch you squirt it through an IV. And that's what we do. It's real practice on your protocol with no math involved. So, age versus length, real quick. Tim Young at Loma Linda, California, did this study where he looked at age, base resuscitation versus the Broslow tape. And you can see, I'm not sure if you can see this graph, this is a Bland-Altman plot, and most of the dots end up in the shaded area. Here's his data. He showed that age is just as good as length. Huh, interesting. So if you use a system where there's no math involved, you can get just as close to the right weight as a length-based tape. That was study number 1. I repeated that study on a completely different data set. We had 2,600 kids. You can see here's my data here in the Bland-Altman plot. This graph looks exactly like the other graph. This is the Broslow tape side. So we found that the two data sets were exactly equal. Age and length are equivalent. So we've now proven twice with the same exact answer that we can use age first. And when you do hear 2-year-old drowning, you should know exactly what to do, just like you do when you hear 65-year-old cardiac arrest. Now you can't, this video, you could probably look it up on our YouTube channel because it just won't come through here, but my son, I have 3 boys, so 2 of them are here, and basically what I do in this video is I give my son an age, let's say 3 years old, and he tells me the epi dose is 1.5 cc's. And I say 7 years old. He says 2.5 cc's. 1-year-old, 1 cc. So I created a little method that I taught myself many years ago because I was so embarrassed. And I said, I have to figure out a way to use age to get right to the volume, so that when they bring me the next dead kid into my emergency department, and the nurse looks at me and says, hey doc, how much epi do you want? I can say, oh, 1 year old, give me 1 cc. And I figured that out because I was so embarrassed of my own self. And then I taught it to my children, and my wife thinks I'm crazy. I taught it to my children, and that's what this video shows. So I'm going to teach it to you guys right now. And so, and again, if you want to write this down, fine. I know that we're recording this. You can come back to it later, but it's very, very simple. The only thing I'm going to ask your System 1 to remember is the following thing. You know the ages, which is 1, 3, 5, 7, and 9. And I teach this on the hand, right? So when I'm doing it live in an audience, I'll say 1, 3, 5, 7, 9. And the weight in kilograms is 10, 15, 20, 25, and 30. And so the first 5 or 6 times, you'll have to kind of say, okay, 1, 3, 10, 15, or 1, 3, 5, 10, 15, 20. But what's going to happen, because your System 1, just like those 2 lines that you thought one was longer than the other, your System 1 is so good that over time you'll say, oh yeah, 1, 1st and 10, like a football. 1st and 10, your brain will make these associations. And so when you hear a 7, you'll automatically hear a 25 in your brain. A 9 is a 30. So this is the one thing you have to remember. And there's nothing else you have to remember. So watch how easy this is going to be. Let's talk about cardiac arrest only. Epi 1 to 10 and amiodarone. Now hear those numbers, right? 1, 3, 5, 7, 9, 10, 15, 20, 25, 30. Now watch this. To get to the epi for cardiac arrest and amiodarone, all you got to do is put the decimal point over 1s to the left, and that's the volume, 1 ml. 1.5 ml for a 3-year-old, 2 ml for a 5-year-old, 2.5 mLs for a 7-year-old, and 3 mLs for a 9-year-old. And that's the volume for both epi and amiodarone. It's the same exact number. So all of cardiac arrest in pediatrics is a decimal point to the left once. How simple could that be? So now, there's no reason for you not to know how to treat cardiac arrest, because it's the same exact algorithm, right? If you look at the PALS and the ACLS algorithm for cardiac arrest, by the way, they're the same exact thing. The medications are the same exact thing. And now you know the dose. Very simple. And again, I'm not asking you to do 0.01 per kilo. No. Forget all that. You have epi, the diluted epi, and then your amiodarone, which only comes as one concentration. And these are both push. So I'll take just a few additional minutes here to go through these medications, because I think it bears just some talking about. Most of you carry epi 1 to 1. Hopefully we're not carrying this anymore. Some of my agencies still do, unfortunately. This is a killer because we don't need this big 30 cc vial anymore. The ampules are a pain because people cut themselves. And now they actually make the 1 ml vial, which is what I would recommend that you carry. But this is epi 1 to 1, and this is epi 1 to 10. So why did they make 1 to 1 epi and 1 to 10 epi? Who came up with that? And the answer is that whenever you give epinephrine or any drug through an IV, you have to dilute it. And so they said, because cardiac arrest is a time-sensitive condition, we'll pre-dilute this epi and we'll make it diluted for you. You don't have to mix it during the code. Fine. And that's the only reason there's 2 different types of epi. But an easier way to remember epi is to think of it like tequilas and margaritas. This is my favorite way of thinking about it. You would all agree that that margarita has that amount of epinephrine in it, right? Of tequila in it. So let me just give you so if this was 1 ml, we poured 1 ml into here, and we put 9 ml of, let's say, just other stuff, right? It's not alcoholic. So would you agree with me then that there's the same amount of alcohol in this thing as there is in this thing. All we did for this was we added more fluid to make it more diluted. That's all we did. So this is really 1-to-1 epi, meaning it is what it is. It's true to itself, and they added a 3 zeros to confuse you. This is 1-to-10 epi. It's diluted by tenfold, and the 3 zeros to confuse you. So basically, I call this cardiac arrest epi, and that's really a way to remember it. They don't want you calling it 1-to-10 and 1-to-1 anymore because they think that's confusing people. But whatever the case may be, just understand that this is just a diluted form of that. Fine. Okay, now, here's where this comes in. So the dangerous thing about this sucker here is that this is the equivalent of 30 shots of tequila. That's a night for me at the Hard Rock. Just kidding. But basically, there's no reason to carry this much epi, concentrated epi, on your rigs. Now, you're only going to use a very small amount of epinephrine, right? 0.3 to 0.5 mLs maximum. So what do you do when you use 0.3 of this thing? What do you do with the rest of it? You throw it away. But remember what the Broslow tape said for epi? It gave you the ET tube dose, which is a tenfold overdose for anaphylaxis. And when you look at the vial you're carrying, and the dose it says on the tape, it says 2.1 milligrams, 2.1 ml for a 5-year-old, you're going to look at this vial and say, yep, that sounds about right. So many people, including yours truly, have made the mistake of giving too much epinephrine, and there's many different reasons why. There's math involved, the tape is wrong, the bottle is wrong, and you're going to make a mistake. I don't care who you are. So think of this as I'm alive and dangerous. You only give epi to IM, people who are alive. Again, I don't give epi through the ET tube much at all anymore because we have the EZ-IO. So you're giving it IM. These people are alive, right? Asthma, anaphylaxis. And it's dangerous because if you give it through the IV, it's not a good thing to do, and you may overdose the patient. So this is a dangerous drug if you don't use it correctly, but if you give it IM, it's harmless. I mean, give it all day long to anaphylaxis. It's not going to hurt anybody if you give it IM. It's very safe. The IV epi, on the other hand, the margarita version, you're going to give in pediatrics anywhere from 0.5 to 3.5 ml. You give it through the IV, and it's only for dead people. Okay, that's just the bottom line. This is for dead people. Okay, so we talked about this already. I don't want to beat this a dead horse here. And so let's just go through it one more time. So now I'm going to teach you the epi 1-to-1 dose. So asthma and anaphylaxis, right? So you're going to walk into a Chinese restaurant, kids having some Chinese food, and they had some cooked peanut oil, and he's going to have swollen lips. The swollen lips, sats are going to be 80%, going to be wheezing, vomiting everywhere. All you got to do is say 110, take decimal point. Instead of moving it over once, you move it over twice. And it's a very small number. It's 0.1 ml. 0.15, 0.2, 0.25, and 0.3. We've already talked about epi 1 to 10,000, and by the way, amiodarone is the same exact number. It's 1, 1.5, 2, 2.5, and 3. Why? Because it's just diluted by tenfold. So, if you remember nothing else from today, you can leave here with full understanding of how to treat anaphylaxis. When I say full, I know you guys know how to treat it, but you know the dose before you get to the scene. And I promise you, if you know the dose before you get to the scene, you'll stay on scene. And you'll look at the parents and you'll say, help is here. We're here to help. Don't worry about it, Mom. We'll take care of this. And then you're going to look at your partner and say, hey, grab me epi 1-to-1. Give me 0.1 ml. Let's give it IM lateral side. Done. Beautiful. And you're going to look at the kid and say, give me high five. I'm here to help you, buddy. And the kid's going to look at you and say, wow, this guy, this gal, they know what they're doing. I feel comfortable. And they're going to, and all of a sudden the world is just a better place. And you're going to feel better about yourself. And you're going to leave that scene. You're going to leave the family saying, you know what? We did everything that we could, and we were rock stars. And all I'm doing is giving you the dose before you get there. Very simple. It's not rocket science. So I'm going to test you here. Here's a 3-year-old boy in the top right of your screen who's getting CPRs and PEA, and let's say you're not on the scene yet, and you want to figure out what your epidose is going to be. So take a moment. 1, 3, 10, 15. The decimal point goes over once, and your dose of epi is 1.5 ml. Now you can get there. You can push on the chest. You can bag the patient. You can start your EZ-IO, and within a minute, you can have your epi on board, and you're rolling. Okay, so I'm not asking you to stay 20 minutes on scene for the first couple of kids you get. Stay 2 minutes, 3 minutes, 4 minutes, but do good CPR. Start your EZ-IO. Give your first round of epinephrine. Look at the parents and say, we're staying here because the chances for your child to live are right now. And it's not for me to get your child in an ambulance. And you have to have someone talk to mom and dad about that. You can't just assume that they know what's going on. All right, next one. 5-year-old girl, peanut allergy. This is the girl I gave you in the beginning, right? 1, 3, 5, 10, 15, 20. And remember, for epi 1-to-1, it's the dilute. It's the concentrated form. It's the tequila shot, so it's going to be a very small number. And the number is very simple. Take the decimal point and move it over twice. And the dose is 0.2 milligrams or 0.2 ml, same number. Easy peasy, right? Done. Now you have asthma, anaphylaxis, and cardiac arrest in your back pocket forever. Right? That's easy to do. So once we get you there, then we figured out another thing. And the other thing is that it turns out that paramedics decide that they're going to leave the scene. You know when they decide they're going to leave the scene? You decide that you're going to leave the scene before you get there. And here's what I mean by that. The most fearful part of getting on scene for most people is this, the eyes, right? And what are these eyes looking when you get off your vehicle? They're looking at you, and they're making a System 1 assessment. And they're saying to themselves, this person is walking confidently, looks confident, it doesn't look pale, is not breathing fast. Okay, I trust this person. And then, so that's barrier number 1 that you have to get through as a medic. And then barrier number 2 is you have to be able to perform all these different, very complex things on scene. I say is, these are 2 different parts of you. And I would even say these are 2 different people. So what we do in our course that we give to people who use our system is that we actually add an extra link in the chain of survival. And that link is basically a pre-arrival discussion. What do I mean by that? You're driving to the scene of this kid who's in anaphylaxis, and one partner says, I'm going to be Dr. Phil, and the other one says, I'll be Dr. House. What does that mean? Dr. Phil is the one who everyone's looking at. You're going to walk right up to the family, confident, and you're going to say, tell me what's going on. And basically, you're going to be in System 1 only. You're forbidden from thinking about a drug dose, a number, a volume, anything. You're going to think, you're going to put yourself in your adult brain. Now, the American Heart Association people don't like me to hear when I say this, but I want you to think, when you're treating a pediatric patient, think like an adult. Think like you're in an ACLS mode. Seizure, think you're an adult seizure. Arrest, think it's adult cardiac arrest. Because if you can do that, you're gonna keep your brain in System 1. You'll make an assessment, that's System 1. You'll know your algorithm, that's System 1. And basically, you're talking to the family, you're making an assessment, and then you turn to your partner. This is the person who is going to know all the drug dosages, no math involved, and you're going to say, hey, House, I need epi 1 to 1,000 IM lateral thigh. Can you get that for me? No problem. And now you're right back talking to the family, you're talking to the kid. You need midazolam for the seizure? Hey, House, let's get some midazolam intranasally. Hey, Mom, what we're going to do right now, my partner's going to pull up some medication, and we're actually going to spray it into your child's nose. In the meantime, all the vital signs look stable, your child's breathing fine, we've added some oxygen. Do you have any questions right now? No, everything's going to be fine. We're going to stay right here and do this. Now, what that does for you is, this person is thinking like he's treating an adult. This person has all the math and has practiced the medications because we've practiced that beforehand. If you make that discussion of who's going to be housed and filled before you get there, everything changes. It's subtle, very subtle, but it matters. So, hopefully I've convinced you that you can do this. This is the Antevy ABCDE. It's different, right? We arrive on scene, we bag, we compress, we drill, we give epi, and I ask all of my medics to please stay for 2 minutes. Now they completely blow me away when they say, Doc, we started off with 2 minutes, then we were at 5 minutes, now we're at 20 minutes. And I can tell you that in Palm Beach County, and we're going to be publishing this data, in Palm Beach County since November 4th when we went live with this system, our ROS rate for pediatric cardiac arrest is 85%. 85%. Now, not all those patients made it, but my medics are coming back and saying, and this is exactly, they're saying, holy shit, we're getting these kids back. We're getting pulses back. And that's exactly what you can do when you stay on scene, you do it right. So, please, I'm begging you that now you have the tools. You don't need me anymore after this. You have the tools to do this tomorrow. Let's give you a couple of other scenarios. Miami-Dade Fire Rescue has been using our system for 5 years now. A few years ago, they had this little boy, Alejandro. He was in that little pool. It's green in Google. It was green the day he drowned. Before he got there, Lieutenant Tammy Napoles and her partner said, we're staying on scene, yes. The dose of epi for a two-year-old is 1.2 ml. And she said, we're going to do this, we're going to do that. The EZIO, we're going to give 1.2 ml. We're going to stay on scene, yes, yes. Okay, they get there, they look at the mom and say, we're doing it right here, right now. They got to the scene, they get this kid back to life. They intubate the kid on the scene. He goes to Jackson in a coma. Jackson's one of the local hospitals. He's in a coma for 9 days. No one thought he was going to make it. They pull the tube out of him. He starts opening his eyes. He starts moving all 4 extremities. And then he goes to rehab. He had to learn how to walk again, how to talk again. This is Lieutenant Tammy Napoles. This is Alejandro. They were finger painting together. He is 100% neurologically normal. He was underwater for 6 minutes. And the only person that we have to commend and to thank is this person and her partner for saying, we're going to stay on scene. I've said it before, I'll say it again. The lives of children are in the hands of EMS providers, not in the hands of the doctors at the hospital. And if I can get you to commit to me that you'll stay on scene for the first 2, 4, 6, 8, 10, 12 minutes and do the right thing, then we're going to get a lot more good outcomes, I guarantee it. Here's another case of one of my medics in Davie Fire Rescue. I want to show you the actual run sheet. Call received 1356, dispatch 1357, en route 1358, on location 01. Contact 1402, 1402 and 45 seconds. This is my medic Torres, who's an all-star, and he knew right when he got on scene the IO was going in. 1403 epi was given. Why? Because he knew the dose before he got there. 1406 epi given again. So I'm telling you, this is proof. This is not made up. They're doing it, and they're doing it without me twisting their arm to do it anymore. So let me talk about Jonathan Robbins for a few minutes again. So I told you the story what happened to him as a rookie. I became the medical director in January 1st, 2015, and we implemented our system. I went and gave the course myself, live and in person, and he was sitting in the very front row. And as you all know, when you go to a paramedic class, no one sits in the front row, right? And so Robbins was right there in the front row all by himself, and everybody else was in the back. So I shook his hand, and I introduced myself, because I was their new medical director. And I had no idea of his history. But this kid, he knew the 13579 already. I call him a kid because he looks so young. He knew the 13579. He was taking all these notes. And he looks at me at the end of the class, and he said, Doc, I hope I never have to use this. I said, me too. Well, what happened a week later? Oh, and by the way, Chief Cardona, my EMS chief, says to me, hey Doc, I hate to break this to you, but these guys aren't going to stay on scene. These guys, these guys aren't conditioned to do that. I said, okay, let's see. A week later, Robbins gets a call. 1-year-old, actually it was an 18-month-old, choked on a grape. He gets to the scene, and guess what? There was a police officer with a dead kid in his hands again. And those memories of what happened to him years ago all were coming back to him. But this time, Robbins looks at the cop. He says, put the kid down. He takes out his blade. He takes his McGill, and there's blood coming out everywhere because the mom was doing finger sweeps in this grape. He suctions out the mouth. He takes the McGill. Boom. He finds the grape while they're doing CPR. His team's doing CPR. Gets a ROSC. This kid walks out of the hospital a day and a half later. That was save number 1, a week after the class. We wrote him up in the paper. A week after that, Robbins gets another phone call. A 2-year-old drowning. Now this was right next to our headquarters, so Chief Cardona hops into his vehicle and he says, I'm going to see this for myself. He gets to the scene a few minutes after. Robbins did again, so Robbins is on the call again. By the time Cardona gets there, Robbins is already intubating on the scene. They've already given 2 doses of epi, and guess what? They got another ROSC back. This child, James Edwards, and his name's been all over the media, been on the Today Show and so forth, is alive today because of Robbins and his team. And that was, just another amazing story. So a few months go by, and now we're at some event we were doing. The chief was serving. We're at a bar. It was for like a breast cancer awareness night. And Robbins comes up to me. I hadn't seen him since the course months prior. He says, hey, Doc. I said, hey, he said, remember me? I was the guy in the front of the room. He says, yeah, I remember you. So we were having some drinks. He says, I have to tell you a story. He says, first of all, I was the guy who had those 2 saves. And I'm like, oh my God, I'm so happy that you were there. He says, but let me tell you the real story. I said, okay. And he says, and then he tells me about what happened when he was a rookie. And he says, Doc, for 8 years I was depressed. For 8 years I was anxious. For 8 years I didn't want to, there were days I didn't want to come back to work. He says, but now that I've had these 2 calls, now that I feel confident in my skills, now that I treat kids like I treat adults, my life has changed. And now this guy is really, he was always a superstar, now he's become a real superstar within our department. And so these were very small changes, behavioral changes, psychological changes, that really made the difference. More data. Polk County's been using our system since 2014. Look what happened before. They had 38 children in cardiac arrest, not many ROSC, not 1 child walked out of the hospital alive. In 2014 and 15, 52 arrests. The ROSC rate jumped up. 71% of 33% survived. 78% of 29%. These 12 kids actually walked out of the hospital perfectly normal. And so I'm telling you it's happening in Palm Beach. I'm telling you it's happening in Polk County. Let's take a look what's happening in Denver, who's been using our system now for about a year. Their fentanyl dose usage went up 116%. Versed went up 197%. They're actually going to be releasing an abstract showing that for children under the age of 6, they now have a 4-time higher rate of fentanyl use. Why? Because now they actually know the dose. They've practiced giving the dose. So things like this make me very, very happy. We're treating kids just like we treat adults. We're giving them the highest level of care. So let me take you back to this street. And perhaps this has been pediatrics for many, many years. And perhaps all the things we've been telling you to do and the tools we've been giving you have been lights that haven't made things better, and hey, maybe they've even made things a little worse. So what I'm trying to do is I'm saying, let's take a bulldozer and let's rip up the road. Let's start completely fresh. And maybe length-based resuscitation was the wrong thing to do from the very beginning. Maybe we should be treating kids like we treat adults. Maybe we should get rid of PALS altogether and incorporate all those pediatric specific things into one ACLS class for EMS providers. because maybe we've scared people to think that kids are something different than they really are. So what is the difference between your ACLS class and your PALS class? Well, it turns out there isn't much difference. So what I would say we should do is have one class, have one set of algorithms, teach both adult and pediatrics at the same exact time, and then we'll have better outcomes. And then we can actually start to feel like we're working, we're on the same team for these pediatric patients and the adult patients. So my ask is layperson and telephone CPR need to be changed. We should use age primarily and length-based tape secondarily. We should treat kids like adults, and then automatically you'll have a culture change and outcomes will improve. And so hopefully that can be done at your departments. And I'll use the next couple of slides to show you, and again, normally I don't do this in these presentations, but I'll just give you a couple of slides to actually show you, because a lot of people leave saying, hey, well, what exactly do you guys do? So here it is, very simple. I'm showing you here our durable goods, which means that, notice here, we have a Pelican box, we also have a bag. But now we have actually made everything age-based, even the equipment pouches. Our length-based tape at the bottom matches up to the Broslow, but there's ages on it now. There's no medication dosages on it. So if you're going to use the tape, guess what? We force you right back into age again. And then we actually have you do that. But I would prefer that you say, 3-year-old, you get there, the kid looks like a 3-year-old, you never pull out the tape. You never show the family that you're doing math. You just do what you have to do. Now, let's take a look at the customization. This is Pinellas. This is in the west coast of Florida. And this is what we're going to be doing for Anchorage and so forth, is that, remember I told you there was a 49% discordance? Well, look, we actually have software that allows you to create, it's a one-time process where you actually make a book that actually has all of your drugs, all of your concentrations, the dose that comes right from your protocol, the route that comes right from your protocol, and the volume is listed for you, so that before you get to the scene of the 5-year-old in anaphylaxis, you open up the book and you say, 0.2 ml IM, and you look at your partner and you say, hey, we're going to do this. So this is customization to the maximum degree. We also customize what defibrillator you have. We customize your airway at the bottom, and I'll show you a little further what we do here. For our critical care agencies and our flight agencies, we have more medications. We have drips. It tells you how to make the drip, how to run the drip, and all the equipment as well. So we have different versions for different types of providers. And we also have adults. So our system goes from a 2-kilo premature child all the way up to a 100-kilo adult. So it's not just pediatrics anymore. So if I can, I'll take about a minute or two to show you what we've done. I'm really excited about this part of it because this has taken us to a whole nother level, which is basically taking all that information and putting it on your laptop, on your Toughbook, on your phone, on your iPad, on your whatever you have. I'm going to move out of this real quick. I'm going to go to this. So what we have right here, you see on the screen, is basically I'm holding my iPhone in my hand, but you could probably do this on an iPad, and again, you can also do this on your laptop computer, your Toughbook. So this is PHI, the large air medical agency that uses us across the country. So when you're going to a patient, all you simply have to do is click on the green button, and I'll do that now. And you can see here that what comes up is ages, weights, and colors. You could take your pick. So let's say we want to go to a 2-year-old, let's say a 2-year-old drowning. So simply push on the 2-year-old. And what comes up here are all the medications customized for this department. So now, let's say I want to give Epi, IV, 1.2 ml. I'm just going to click on that. And then I just click on here. I'm giving it. And it turns green. And let's say I want to give some fentanyl next. There's the dose, 0.24 ml, right from what your protocol would say. Remember, this is customized to you. Let's give some Benadryl, 0.24 ml. Remember I asked you about the dextrose dose earlier? We have 2 choices now. B10 is 60 ml. Let's give that. Done, given. Now let's say you want to go to your equipment. Go down to the bottom here, equipment. And it's got all your equipment. Let's intubate this child with a 4.5 cuff ET tube. Let's say that was unsuccessful. I pressed the red button. So let me go ahead and put my eye gel in. Eye gel, size 2. Green button, successful. Done. Now I have drips. Go down to my drips. Let's say I want to start a fentanyl drip. It tells me how to mix it, how to run it. Click on that. Given. And now I want to go to my electrical. I want to defibrillate. Click on electrical. They have a Zoll monitor, 20 joules, rhythm converted. So now watch how fast I can go back to medications. I can give adenosine. I can go back to equipment. I can put a suction catheter. I can go back to drips. I can give amiodarone drip, and so on and so forth. And every time I push on here, we're documenting, and guess what? All of this information then flows seamlessly right into the medical record. So there's no double documenting. You're on scene, the dose is being delivered to you right there, you're giving the dose, and just by pushing the button given, it's being documented in your ePCR. And so we're working with companies all across the board to integrate our technology into their medical record, so to make it easy for you in the long run. So that's something that we're really, really excited about. So we're right at, I have 2243 here. I'm putting up my contact information. If you want to follow us on the social, you can do that here. And this is my personal and direct email address. And Lizelda, I am going to pop it back over to you for questions, and I hope there are some. And I hope you guys enjoyed that presentation.
Right, so if anybody has questions, now would be a good time to ask it. Go ahead, you can either put your hand up in webinar land, or you can type in your question. I can ask it if you don't have a mic. Does anybody in the class have a question? Huh? I'll go with hands. No
Come
questions?
on, guys, don't be shy.
Yeah, no. No questions in webinar land? Go ahead, we've got one in the class. Go ahead.
For the ABC,
All right.
Speak now.
oh, so for the ABCDE, the D for drill, is that for an IO?
Right, exactly. Let me go back to that we can show you that part of it. Hold on. So let me go back to that slide so everyone can see that in a second. It's here somewhere. There it is. So it's A, arrive, B, bag, C, compress, D is drill, and E is epinephrine.
Okay, all right.
And you know, obviously, the child would have. In other words, this is a cardiac arrest that would require epinephrine. Obviously, most of the arrests that we're going to run on in pediatrics are not going to need electricity. But obviously, if they do, they should get that as well, and probably as a priority. But most cardiac are going to be in a system.
Thank you.
So we
You're welcome. Thanks
had,
for asking the question.
we had a question in webinar land that asked if the app that was shown, if it's available on its own or is it part of a larger package?
Right, so you can download the demo version right now. You just type in Antevy to the Google Play or Apple or iTunes, everything, and then it'll ask you for a username and password. And so we've created a demo that's got no dosages in there. Like, it won't show you the actual volume; it'll just say 0. But the username is Antevy and the password is Antevy. And yeah, we would love for you guys to download it and just play with it. Now, I didn't go through all the features, but you could also be at a hospital and you can fax or email your entire run record of all the medications or equipment that you gave right to a fax machine or an email address, and then once we connect into your electronic medical record, it'll flow seamlessly into that medical record. So I just gave you a very brief 30-second version of it, but please download it. Username Antevy, password is Antevy, and that'll give you the demo.
Any other questions on webinar land? Anybody else? Any cases or anything, you guys?
And so I'll put up my email address because I know I do so many webinars that I know that a lot of times people are just shy to ask a question. But if you are and you want to ask a question personally, you can just there's my information. And again, we look forward to working with you guys in Alaska. I know that I think we're just getting the book creation information done. Actually, if we have a second, I'll show you exactly how that happens. Let me do that. Do we have a few minutes, Zelda, still?
Sure.
Okay. So basically, only because it turns out that the process of creating the process of let me do this first before we the actual process of creating this complexity of a book in pediatrics is it was very difficult. We took a long time. This is software that our team created. It's proprietary software that enables whatever agency to log on. So I'm kind of logging on as if I was a customer, let's say. And essentially, so basically all you do here is you click on a tab, let's say resuscitation, and let's say you're an agency that carries blood. Boom, you click on blood, and it auto-populates with what typically people would use for blood. For let's go into something else. Let's say I won't use vasopressin. Let's say normal saline. You click on normal saline. Well, for preemies and newborns, we use 10 per kilo, and for everyone else, we use 20 per kilo. But again, all this is customized. So essentially, you can click open this button. You can say, you know what, I want to give 20 per kilo to everybody, preemies and newborns. And instead of 20 per kilo, I want to give 25 per. Let's say I want to give 15 per kilo, and my max dose will be 500. So we allow you, the customer, to actually do exactly what your protocol says. And if the dose seems a little too low, we'll remind you of the fact that that doesn't seem like a normal dose. And so at the end of this process, a web-based process, you end up with one of those customized books. And some people can do it in a couple of days, some people it takes them a couple of weeks, but that's the process that we take every single agency along with. And then as part of what we do afterwards is we actually say to this agency, we want to be your pediatric emergency resource 365 days a year. And so we have an entire training portal. And I mentioned to you that we have a course. All of the agencies in Florida who use us don't use PALS anymore, they use our course. And we continue to give education and webinars. We do things like these frequently on seizure control, pain control, drowning, and so forth. And so what we're trying to be is a pediatric emergency resource for EMS across the country. And that's something that we're very passionate about, and that's really our mission.
So question,
go ahead.
Somebody asked us, what are your recommendations for children that are much larger or smaller than their actual age?
Great question. I'm happy someone asked that question, because that question usually comes up. So, and I have a slide buried in here somewhere, but instead of looking for it, I'll just tell you the answer of how I view it. Is most medications that we give are distributed into the total body water of the child, meaning that if you have 2 3-year-old children the same height, but one is larger, meaning has an extra layer of fat on them, if you give them morphine, it doesn't matter how fat you are, the morphine doesn't see the fat. So what I would recommend is giving the ideal body weight for most medications. The 2 medication exceptions that you should know are amiodarone. For, if you're a heavy child, you need more amiodarone. You need your actual body weight. Another medication is succinylcholine, which we rarely use in pediatrics, if ever. And so basically, all the other medications, the benzos, all the narcotics and so forth, you should give ideal body weight medications, which is length-based tape or age, either one. Those are ideal body weight. Now, if you come up to a kid who's taller, very much taller, or a lot shorter, like a chronic child who's 7 years old who looks like a 1-year-old, then we would recommend highly that you take the tape out and you use the tape. And so in those scenarios, which is again maybe 5% of the time, you'll end up finding yourself using the tape. The pediatric ER people across the country, I would just look at the kid and say, that kid doesn't look 3, they look 5. Hey, let's go with a 5-year-old. So over time, you can develop that ability. If not, use the length-based tape. I hope that answers the question.
Yep, they said that did answer the question.
And by the way, that's all stuff that we teach in our course, by the way. So it's a very good question.
So, hearing no further questions, Dr. Antevy, thank you very much for your time. We appreciate you're a busy guy for taking this time out to share your thoughts and teaching us about pediatrics and taking some of the nerves out for us, because I think we're all still scared Scooby-Doo. So, but we really appreciate it. We're going to miss you at the symposium, but we'll try and get you up here for sure. So
I appreciate that.
And
all right.
Out of
Thank you.
Westmoreland, if you can send your, we're a group tonight, to send your rosters to the email on your screen right now, so that we can go ahead and get you guys CME printed. And you guys will get an email with when your CME certificates are available. So please, if you're in a group tonight, go ahead and send your group roster to that email. And thank you again, Dr. Antevy.
Thank you, everyone. I appreciate it. Have a great night.
Have a good night. Thank you.
Okay, bye-bye.
Any thoughts from you that were here?
I hate math.
So much.